Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
Welcome to The Health Advocates, a podcast that breaks down major health news of the week to help you make sense of it all. I'm Stephen Newmark, Chief Policy Officer at the Global Healthy Living Foundation. Our goal is to help you understand what's happening in the healthcare world to help you make informed decisions to live your best life. Today, we're joined by Dr. Tyler Evans, an extraordinary infectious disease and public health expert whose career has taken him from the front lines of 2 Ebola outbreaks in Africa to serving as New York City's first chief medical officer during COVID-19 to founding the Wellness and Equity Alliance. Dr. Evans is also the author of the upcoming book, Pandemics, Poverty, and Politics, Decoding the Social and Political Drivers of Pandemics from Plague to COVID-19 from Johns Hopkins Press. In it, he takes a deep and personal look at how inequality, poverty, and political choices shape and often worsen pandemics. Dr. Evans, welcome to the Health Advocates.
Thanks. Great to be here.
Yeah, let's start. Your book opens with the paradox that millions die from preventable diseases despite unprecedented wealth and technology. What was the moment or experience that crystallized this reality for you?
I'll start with something, really the first sort of image that comes into my mind, which was I was working in South Sudan. I was the only doc for 29,000 refugees or internally displaced people, which are essentially refugees that can't cross borders, which is worse. I was standing up a pediatric malnutrition hospital. Now, I was neither a pediatrician nor a nutritionist, but at MSF or Doctors Without Borders, you basically just figure it out. So throughout this process, you can imagine the type of malnourishment that I saw, and I devastatingly saw a number of children that were incredibly sick and some infants that essentially died in my arms. As that was happening, the World Cup was on. And so there was a little TV. It was maybe like less than 12 inches. And it was a little black and white sort of screen and this really sort of tenuous signal. And we were watching this sort of football. But at this time, I was going in there to get a Nutella sandwich. And what I saw on the screen was the show The Doctors. And on the show The Doctors, they were talking about morbid obesity and these sort of like fad diets, Atkins diets, or whatever they were talking about at the time. And I was just thinking about these sort of paradox of these sort of two realities that were sort of connected in time, but very much sort of disconnected in space. And these two realities would probably never sort of see each other, And so we had all of these resources and all of this abundance in places like the US. And then I'm in essentially the most nascent, newly formed country in the world where millions essentially were sort of eking out their sort of daily struggle to just get some basic food. And mothers were unfortunately having their babies die in their arms. And so that's a world that should not exist. We should have a little bit more even sort of distribution of sort of resources there. That's always been a sort of compelling image when I'm thinking about the paradoxes of our world today.
Yeah, no, it's interesting, those paradoxes. You've worked in conflict zones, refugee settings, and some of the world's most resource-limited areas. How have these experiences shaped the way you think about the U.S. healthcare system?
Essentially, throughout my career, I worked in the Global South for many years in places like South Sudan, Central African Republic. I worked on the Ebola response twice in both Sierra Leone and Democratic Republic of Congo. Again, war zones, conflict, humanitarian emergencies. And so with all of that, I come back to the States and I'm working in Indian reservations. I'm working on the South Bronx. I'm working in South LA. I have actually a theory about the Souths. And the reality was the drivers of all of these sort of issues from a healthcare standpoint were very similar. The drivers, the determinants were often socially determined or politically determined. And that really, throughout time, those sort of anecdotal experiences started to really kind of shape my perspective, and sort of my frustration was channeled into a more sort of concrete understanding of what was actually sort of happening here and ways to sort of address these sort of issues. And so kind of seeing all these experiences throughout the years, again, allowed me to sort of weave together these sort of ideas and now actually provide a response to those sort of inequities. And so we formed this new organization called Wellness Equity Alliance, where we actually sort of try to work in between the cracks in the pavement, as it were, to essentially try to sort of fill those gaps.
From your perspective, what is the most misunderstood link between politics and public health outcomes?
The basic misunderstanding is that politics should not be involved in public health really at all. Politics really has no place in public health. Public health is a common good. It should be completely depoliticized, and it's there to protect our populations from things that they don't understand, from environmental health sort of threats, from occupational sort of health threats, from emerging infectious or communicable diseases, from cigarette smoking, from a lot of different sort of elements that it is not necessary for them to sort of really kind of think through, and through the government that it is funded in order to kind of provide that sort of protection. So this is a basic utility that is provided throughout the world. And in many countries, it works very well. In the States, it generally works well. There are inequities. I mean, New York City is one of the best health departments in the country, is the largest for sure. But yet there has been an increasing sort of politicization of public health. Particularly, this was accelerated during the COVID-19 pandemic. We've never saw this before, essentially, where this country has historically been divided by 3 or 4 different elements, typically sort of religion, abortion, guns, a few other elements. But who thought that face masks and vaccines would ultimately be sort of this final polarizer? The reality is that it has become politicized. It is becoming further politicized during this current administration. And as a result, all Americans are going to get hurt.
Yeah, no, it's sad, some of the issues that you described about the politicization of public health. We talk about that a lot on the show, and something we address a lot at the Global Healthy Living Foundation. Just moving back to your book, you use case studies like HIV, AIDS in South Africa, and Ebola in West Africa to illustrate socio-political drivers of pandemics. Which example do you think is most relevant to what we're facing in the US right now?
When I describe these correlations, I connect it to something. There's a chapter in my book called population stress. So the easiest way to break this down is to sort of, when you think about a person's individual sort of immunity, their immune system tends to be relatively robust. It tends to sort of wane over time. If you take a situation like herpes is always a pretty easy sort of manifestation, because when it comes to herpes simplex 1, which is the sort of oral herpes, more than 70% of people have it. They claim to not have it. They just call it something else, but the reality is it is herpes. And so herpes will manifest during times of stress. And stress could be either actual emotional stress or it could be physical stress. You could actually be sick, or you could literally just be stressed out. The immune system perceives it the same. And so when we take populations that are sort of consistently stressed over time, whether that's sort of access to healthcare, education, nutrition, other sort of basic elements, sleep, et cetera, particularly with homelessness, when you take these populations and you sort of, and particularly when those components sort of cascade together, you ultimately find that the population sort of lose any sort of immunity that they once had, any sort of immunity that they had, any protections that they had against sort of emerging threats, particularly against emerging sort of communicable diseases. And so we saw that with HIV, particularly during apartheid, when there was a lot of sort of infighting and the virus was first detected in 1981. The reality was this was baking for several decades, right? We didn't have the sort of detection mechanisms in order to sort of identify it. But we posit that essentially it had been baking, again, for decades in places like sub-Saharan Africa. And so in South Africa, it was really sort of accelerated as the result, again, of this sort of infighting and this population stress that was happening as the country was fighting one another, essentially was close to a civil war. Same thing when it came to Ebola. You have a place like Sierra Leone, essentially had decades of fighting prior to, with rebels fighting the sort of the government systems. It was very sort of well known, and in books and movies like Blood Diamond. And so as a result, they were sort of a perfect opportunity for something like Ebola to sort of come in and sort of manifest, because the populations didn't have the ability to withstand the sort of the stressors. Whereas another sort of society that had a little bit more kind of a robust sort of immunological mechanism, as it were, I'm speaking metaphorically, would be able to kind of withstand that. So in the US today, it's a perfect scenario where essentially as this country is getting further politicized and as sort of the red and blue states are getting further sort of clashing with one another, I mean, we have ICE coming in and disrupting factories and homes throughout Los Angeles, where one of my teams is based. We have national troops that were deployed in California. We have national troops that are currently deployed in Washington, D.C. I mean, this is the perfect sort of scenario where our systems of governance are getting further stressed. The people that are historically marginalized or vulnerable are at the greatest risk. And so as a result, those folks are going to, when the next emerging communicable disease comes, and they are coming, I mean, we are tracking them, whether we're looking at chikungunya, whether we're looking at Chagas disease, particularly respiratory sort of infections, are from a sort of transmission mechanism standpoint, are the most efficient. And certainly when we're looking at influenza sort of permutations, that's always going to be a sort of risk factor. But we're all going to be at risk. All Americans are going to be at risk, but particularly the most historically marginalized because of that population stress.
Fascinating. There's so many questions that are in my mind right now based upon what you were just saying, all the mistrust. How can we rebuild the trust that has been eroded in the United States and elsewhere, but mostly in the United States, that was once a world leader? How can we rebuild the trust?
The best way to rebuild it is really three different things. I mean, we need to kind of focus I'm talking from a public health and healthcare standpoint. What we need to do is, one, we need a more coordinated response to certain sort of threats that are taking place. Now, those could be chronic or those could be acute. That's one. Two, we need better data systems that can really sort of detect these elements in a really meaningful way using things like sort of ArcGIS. We can put together heat maps and we can identify particularly sort of access barriers that are socially determined. We can look at human traffic. There's a lot of different sort of elements that we can look at. And number three, we need trusted messengers. We need the trusted messengers that really can sort of connect to the communities. And if you take those all three together, what we're talking about is basically a way for us to understand the inequities in healthcare and public health, number one. Number two, and then understand the response to it. And understand that, and particularly this response needs to be coordinated. So what I'm just describing is basically more effective sort of system agencies sort of working together with one another. When the COVID pandemic hit in New York City, I was the first chief medical officer, and the New York City Department of Health and Mental Hygiene essentially had been sidelined for a number of reasons, for political reasons. And so health and hospitals, which was a public hospital system, ambulatory care system, didn't really have the sort of the infrastructure to respond to a public health emergency because that's not what they were sort of really built up for. And so the Office of Emergency Management, where I was placed, had to sort of come in. Now, they didn't really have the chops to respond to public health emergencies. It wasn't something that they had historically been sort of set up for. And in fact, the health and medical section had less than 5 people in it, with like a family medicine doctor and a few nurses and a few EMTs. And so we said, we got to get a bigger boat here, famous Jaws reference. And we ended up getting about 4,000 to 5,000 people underneath this new sort of collaborative initiative. But what myself and a number of other leaders did throughout the city, both at Department of Health and Mental Hygiene, H&H and other sort of agencies, was we came together and we created a systems integration sort of process so that all agencies were able to sort of work together in a coordinated fashion. We did the same thing during HIV in the 80s. The famous sort of red ribbon essentially was UNAIDS, basically cutting through the red tape so that a number of different sort of international agencies could come together. So that's what we need. We need a coordinated response so that we can work together. And that's what happens often during emergencies. You have the EOCs come in, emergency operations centers. So essentially all that sort of red tape or whatnot, all that bureaucracy, all the funding, all that sort of dissolves and these organizations can work together more effectively. We need more sustainability of that from a federal to a state to a local level. And the reality, you cannot have the feds and the states sort of arguing with one another during emergencies. It's the same, I often cite, if you're in the emergency room and you have 2 doctors that are openly arguing about your diagnosis and your treatment, your confidence in that sort of system is probably going to erode pretty quickly, right? So what we need the feds to be working, and there's organizations out there that literally are set up to provide that coordination. ASTO, which is a state and territorial health officials organization, brings state health departments together. You've got the Surgeon General's office, which basically commands the public health military task force. And then you've got, obviously, CDC, you have ASPR, you have so many different agencies, organizations that could be effectively kind of working together. And then, of course, you have the city and the county health departments. So if those were all working together, and then the trusted messengers, your community-based organizations, your interfaith organizations, your organizations that really reflect the values that are important to local communities. And you can't do that from a national level. I mean, we know that we're a very incredibly, very divisive world, and that's okay, right? I mean, that's through a sort of pluralistic society, which we have here in the US, we're bound to have a number of different sort of ideas and beliefs. That's a beautiful thing. So the important thing, though, is having all of these different agencies coordinated together and then connected in sort of parallel tracks, connected to those CBOs and those community health workers particularly. We work a lot with CHWs because, again, they have the faith and the trust of those communities in ways that the doctors and nurses don't have.
In terms of future pandemic planning, you've worked extensively. You were talking about ICE, you've worked with the migrant community, you've worked with the LGBT community, people experiencing homelessness. What kinds of policies do you believe are needed to ensure that these groups are not left behind in pandemic planning in the future?
It's a sort of segue from our kind of last point, which was you have to ensure that the communities, especially the communities that are at risk, are at the table, right? At the beginning. You can't allow these folks to sort of get the message or get the memo essentially months to years sort of later. It's got to be at the beginning. And so we can set that up. And New York has done that, where essentially there is a community emergency response where the minute that there are emergencies that are sort of boiling, there are certain community leaders that are sort of notified and identified, and everybody's at the table sort of talking to one another. Again, a place like New York, you've got the New York Immigration Coalition, you have organizations that represent the LGBTQIA, QIA+, you've got, obviously, when it comes to sort of HIV, you've got ACT UP, so many CBOs, and that's a perfect example is HIV. During the 80s and 90s, and Fauci was amazing at this, he really allowed, when he was at NIAID, he really allowed the CBOs and the advocates and the champions to basically work together hand in hand with the scientists to kind of get this done. And that's one of sort of the most perfect sort of examples or representations of effective sort of response. And as a result, well, we were very close to ending the epidemic. Now with recent changes, we're going further sort of away. But again, the message here is a connection, a coordinated response at the very beginning with the key sort of community leaders.
It's good to hear, I have to say, that there are things that can be done. I'm very fearful if something were to come on the horizon in the next few years, that a lot of this stuff perhaps will not be done, unfortunately. But let me ask you a final question. For our listeners, many of whom are patients and advocates, what are some actions that they, as patients, as caregivers, can take to strengthen our collective ability to respond to future outbreaks?
So we sort of describe it as power sharing, not empowerment. So our communities really need to be sort of sharing power as much as possible. And so how do we do that? One, we need the right information. How do we get that? It's really connecting with your primary care providers, connecting with the public health departments, connecting with your trusted messengers, provided they have that right information so that they are sort of teed up and they're in the know in terms of sort of what's happening. There's a lot of misinformation out there. So we don't go on your social media and just sort of assume that the information that you're getting is right. You have to be fact checking that stuff. Listen to the doctors, listen to the scientists, right? Like there's a reason why science exists. It is despite the fact that there's all this sort of threats to the sort of the bedrock of science, the reality is science has been tried and tested for centuries, and it is there to essentially provide a reproducible element of information gathering and analysis. Listen to the scientists, listen to the doctors, and make sure that the intelligence that you're getting is sort of accurate. And then act up, voice up, create some good trouble. Citing John Lewis, like create some good trouble if you need to. Connect to, it's sort of cliche to say connect to your Congress sort of folks. I mean, given the sort of the effete nature of Congress right now, but connect to community leaders, connect to government stakeholders as much as you possibly can. Act up, speak out.
Yeah. Well, Dr. Evans, thank you so much for all that you do, for all of your insight, for your decades of work in global health, and for sharing your expertise with our audience today. And for those who want to learn more, we'll link to Pandemics, Poverty, and Politics in the show notes, along with Dr. Evans' website and the Wellness and Equity Alliance. Thank you, Dr. Evans.
Thanks, Stevie. Great to be with you.
Thanks for listening to The Health Advocates, a podcast that breaks down major health news of the week to help you make sense of it all. If you found this episode helpful, please leave us a rating or review and share it with someone who cares about healthcare policy. And be sure to follow us wherever you get your podcasts. You can find all of GHLF's podcasts at ghlf.org/listen. I'm Stephen Newmark. We'll see you next time.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.